Okay, so we're going to be talking about CSF leaks. So our goal is here to review the clinical and imaging features of SIH, or syndrome of intracranial hypotension, and we'll classify the three major types of CSF leaks and the options for imaging workup. And then at the end, I'll go over some of the treatment options for these disorders. So what is SIH? Well, it's a debilitating disorder characterized by postural headaches. So headaches worse when standing that will be relieved partially or completely with lying down. And that's due to a spontaneous CSF leak causing CSF hypotension. And the International Headache Society has defined SIH by three criteria. So one, you have to have low CSF pressure, being an LP with an opening pressure under 6 centimeters of water, and or evidence of CSF leak on imaging. Two, the headache has to be developed spontaneously and temporally related to discovery of a low CSF pressure. And lastly, you have to exclude other causes of headache. And in terms of as Eric said, this is becoming more and more recognized as a disorder. The incidence in the literature is supposed to be 5 cases per 100,000 per year, but this is a gross underestimate due to lack of recognition and misdiagnosis of SIH. So for sure, you will see these patients in your practice. For clinical presentation, the hallmark is headache. Again, it's postural in 97% of patients. So the headache develops within 15 minutes of standing, and it's usually located in the occipital head. And I will point out that there are 3% of patients that have no headache but have SIH. And furthermore, 8% of patients with SIH don't have that classic postural headache. They may have a constant holocephalic headache, for example. In terms of age, really any patient can get this, range from 2 years to 88 years of age, with the average age at 42 and a half. And it's slightly more common in females than males. And these often have a delay in their diagnosis. So diagnosis is anywhere between 1 day of symptom onset to 20 years. We've seen patients that have had headaches for decades that were misdiagnosed with this disorder. In terms of the cause of CSF leaks, there's 3 types. So type 1 leaks are the most common cause, and these are due to a dural tear, a defect in the dura. That's most common ventrally, but it could also be dorsally. With these tears, what happens is you get degenerative disc disease, often with a calcific microspur that tears the thecal sac. And these are most commonly seen in the lower cervical spine or upper thoracic spine, and they're characterized by a rapid rate of CSF egress into the epidural space because of the big hole here. Type 2 leaks are due to leaking meningeal diverticula. This is when you have a dehiscence along the nerve root sleeve that usually occurs at the axilla, so the junction of the nerve root with the spinal cord. And they can either be simple diverticula in type 2 leaks, or they can be more complex, bizarre-looking diverticular dural ectasia in type 2B. And these are most commonly located in the lower thoracic spine. And although it's characterized by a high rate of CSF leak, it's a little bit slower than type 1 leaks. And then we have type 3 leaks. This is pretty amazing. These are CSF venous fistulas. This entity was only first described in 2014, so we haven't even known about this for a long time. And what these are, they're direct communications between the thecal sac and a paraspinal vein, and they usually occur distally along a nerve root sleeve. These are most commonly seen in the thoracic spine, and these are characterized by a slower rate of CSF leak. So brain MRI is one of the diagnostic criteria for establishing a diagnosis of SIH. So it's a mandatory study. It helps confirm the diagnosis of SIH, and you can exclude other causes of headache. And I'll point out that almost 20% of patients with SIH have a normal brain MRI. So don't be fooled by that. These patients may still have a CSF leak if their brain MRI is normal. In terms of the protocol we use, you have to make sure you have FLAIR imaging, a susceptibility image, and you need post-contrast imaging when you're working up SIH, as we'll see why shortly. And so why do we see abnormal findings on a brain MRI with a CSF leak? Well, it all goes back to the Monro-Kelly hypothesis. You may recall from medical school that the skull is a fixed, rigid compartment, and inside the skull, 80% of the volume is occupied by brain, 10% by blood, and 10% by CSF. So if you have a CSF leak and deplete this 10% CSF volume, the brain cannot expand to fill that vacuum. Only the blood pool can. So you get engorgement of the blood pool inside your head, and also you'll have loss of buoyancy of the brain due to decreased fluid in the intracranial compartment. And so let's see what that does to the brain MRI. So for venous engorgement, the findings we see on brain MRI are diffuse pachymeningeal thickening and enhancement, pituitary gland enlargement, distension of the dural venous sinuses, and subdural collections. So for pachymeningeal thickening and enhancement, this is the number one most common finding you will see in a patient with SIH. It's present in 83% of cases. And the thickening and enhancement tends to be diffuse, linear, and smooth. No real nodularity here. Your differential for this finding alone would include things like infectious meningitis, granulomatous disease, neoplastic disorders, IgG4-related disease, or we sometimes see this in patients that have had recent surgery or even a lumbar puncture can cause this appearance. Pituitary gland enlargement, this is reported in 38% of patients with SIH. You could see the enlarged upward convex border of the pituitary gland. Your differential for this finding alone might include things like a pituitary adenoma, inflammatory adenohypophysitis, or maybe pituitary hyperplasia. Venous distension sign. So this is the second most common finding reported in SIH. This occurs in about 2/3 of patients. And what we're looking for is bulging outward convex margins to the dural venous sinuses. And usually we're looking at the distal third of the transverse sinus on your sagittal image. That's the best way to see venous distension. It's been reported for superior sagittal sinus and the cavernous sinus, straight sinus, but it's really best seen on the sagittal and the transverse sinus. Subdural collections, this occurs in about 35% of patients with SIH. In the majority, 60% of cases, they tend to be subdural hygromas, so simple subdural fluid, but hematomas occur in 40% of patients, like in this example where you're seeing T2 shading, and that's due to stretching and tearing of the bridging emissary veins from the cortex to the dural sinuses. The subdural collections tend to be frontoparietal or holohemispheric, and they're usually bilateral and relatively symmetric. And the size really ranges from little slivers of fluid to huge compressive subdural collections with mass effect on the brain. And then brain sagging. So again, due to depletion of the intracranial CSF volume, we've lost normal buoyancy forces on the brain, so the brain's going to sag. So you'll see effacement of the suprasellar cistern. You'll see flattening of the pontine belly against the clivus. You'll see narrowing of the mammalopontine interval, and you'll see downward cerebellar tonsillar herniation. So for effacement of the suprasellar cistern, this is measured as the interval between the optic chiasm and the top of the pituitary gland. A measurement of less than 4 millimeters is considered abnormal. I'm not a numbers person. I never measure this. I just eyeball it and estimate it, but you can see there's narrowing between the optic chiasm and the pituitary gland. The other finding to look for is if you see this draping of the optic chiasm over the sella, that's a finding of brain sagging as well. For effacement of the prepontine cistern, again, this is going to be measuring the distance between the ventral surface of the pontine belly and the posterior face of the clivus. If that is less than or equal to 5 millimeters, that's abnormal. But the more helpful finding that I look for is when you have this flattening, smushed appearance of the pontine belly against the clivus, then you know there's sagging. And then for narrowed mammalopontine interval, this is the distance between the inferior aspect of the mammillary bodies and the top of the pontine belly. If that number is less than 6.5 millimeters, that's considered abnormal. And then this finding is the most famous finding in SIH. This is when you have low-lying cerebellar tonsils. This is the third most common finding in SIH in the brain in 61% of patients. And I'm going to focus on this for a moment because this can be confused with Chiari 1 malformation. Or to put it another way, Chiari 1 patients are, due to the imaging overlap, patients that have SIH may be erroneously operated on because the surgeon or radiologist has called a Chiari 1 malformation. So we're going to focus on this a little bit. So SIH versus Chiari 1 malformation. So SIH will have low-lying cerebellar tonsils, but typically the tonsils won't be further or will be less than 5 millimeters below foramen magnum. The tonsils have more of a rounded configuration in SIH. You're going to see midbrain descent with these SIH patients. So effacement of the pontine cistern and suprasellar cisterns, and look for that dural thickening and enhancement on your post-contrast images. Now, in contrast, Chiari 1, the tonsils tend to be more low-lying, so greater than 5 millimeters below foramen magnum. They'll often have a peg-like or beaked configuration, and you might see ancillary signs like a cord syrinx on the included images of the upper cervical spine. So both SIH and Chiari 1 have downward tonsillar herniation. However, SIH has brain sagging. So you can see all of the findings that we've just been through: narrowing of the suprasellar cistern, mammato-pontine interval, pons is smushed here against the clivus. And if you were to draw a line from the dorsum celli over to the junction of the straight sinus and vein of Galen, that approximates the location of the tentorial incensura. And if you look at the top of the cerebral aqueduct, which is also called the iter, you can see the iter is draped beneath this imaginary line. So the whole posterior fossa is sagged. With the Chiari 1, you don't see any of those findings. The iter is proud, it's way above the tentorial incensura. All of the basal cisterns are preserved. So that's how you can distinguish SIH from Chiari. So let's look at a couple examples. This was a 52-year-old male with 3-year history of headaches. On the sagittal T1 MR, look at the tonsils. They're actually quite down and they're peg-like in configuration. So at first pass, you might be, oh, this is Chiari 1 all day long. But no, look at the suprasellar cistern. The chiasm is draped over it. Look at the pontine belly. It's flattened here from pressing on the clivus. And then look at the mammato-pontine interval. The mammillary bodies are actually touching the top of the pons. And then we're going to look at our contrast images and look at there's diffuse pachymeningeal thickening and enhancement. This is SIH. Please don't call this Chiari 1. Now, contrast that to this 21-year-old female with 3-year history of headache. On the sagittal T1, at first glance, looks very similar. Look at the tonsils, they're way down, they're peg-like, but then look at all of the basal cisterns. There's no narrowing between the chiasm and pituitary. Mammato-pontine interval is good. There's no flattening the pontine belly. And then we're going to check our post-contrast images. There's no pachymeningeal thickening and enhancement. So this indeed was a case of Chiari 1 malformation. So now that we've looked at the brain findings in SIH, let's move down to the spine. This is critical to evaluate in cases of suspected intracranial hypotension. So for the spine protocol for CSF leaks, you basically need heavily T2 weighted images and T2 fat saturated images. So we do KISS or Fiesta images through the entire spine with axial and coronal reformats. And we also do sagittal 3D T2 weighted images like a HASTE or SPACE with axial and coronal reformats. And what we're looking for on spine MRI is epidural fluid collections. We call these SLecs, spinal longitudinal extradural fluid collections, that these extend greater than 2 vertebral segments. So you can see dorsally there's some fluid, ventrally you can see a collection, and then dorsally as well in the upper thoracic spine. And then look at the axial image, you can see this crescentic fluid behind the thecal sac here. So this is a SLEC. Now, you can also look for meningeal diverticula in these cases for type 2 leaks. And those abnormal diverticula tend to be big ones, larger than 8 millimeters, or those with a bizarre morphology. So really our decision point when you're reading these spine MRs and SIHs is there a SLEC or not? That's all you need to know. So if we're SLEC positive, like in this case on the left, there's an extensive dorsal SLEC. That's caused by a fast leak. So that's going to be a type 1 leak, a dural tear, or a type 2 leak, a leaking meningeal diverticulum. If the case is SLEC negative, like on your right, this means there's a slow leak. That's a CSF venous fistula, a type 3 leak. And that's going to matter for the approach to working up these patients further. So this is our algorithm that we use at MGH for SIH. So patient with clinically suspected SIH, they're going to get a brain and total spine MRI. And then if we see a SLEC, we're going to move on to non-contrast CT of the total spine to look for a calcified end plate microspur, and then we're going on to dynamic CT myelography of the spine. If we find a leak, patient's treated. If not, we might do a trial of an epidural blood patch or repeat the myelogram. Now, if there's no SLEC on that total spine MRI, we're going to do a standard CT myelogram, and we will position the patient in supine left and right lateral decubitus. If we see the leak, patient will be treated. If no leak on the standard myelo, we go on to a lateral decubitus digital subtraction myelogram. If we see a leak, we treat. If not, then consider repeating the myelo or blood patching. So how do we do a dynamic CT myelogram? Well, at our shop, we have the patient lying on our procedural CT scanner on a carbon fiber board. We then use CT fluoro to place a 22 gauge, 3.5-inch Quinky needle into the fecal sac, and we inject about 10 cc's of IsoView 300M contrast. We then will have a lift from the ceiling to the foot of the carbon fiber board to tilt the patient head down on the CT for about 10 seconds and then lower them down and send them through the scanner. And we'll scan through the entire spine and repeat as necessary till we've found the leak. For digital subtraction myelography for DSM, in this case, we do this in the fluoro suite, and the patient will be lying on their side, and we'll set up 2 runs, one of the cervical to mid-thoracic spine, and then a second run from the mid-thoracic spine through the lumbar spine. And we drop 2 syringes. The first syringe, we have 6 cc's of IsoView 300M, and then the second syringe will have 5 cc's. We then set up a digital subtraction angiogram run at 2 frames per second with a run length of at least 80 seconds. We then stick the needle in using fluoro guidance into the lumbar spinal canal, and then we set up with the patient tilted 10 degrees head down on the fluoro unit, and we do a DSA as we manually inject the contrast at a rate of 1 cc per second, and then follow it with a 10 cc normal saline flush. And we do that for both the upper and lower runs. And so you can see here the patient's on their side, and you're seeing the nerve root sleeve starting to fill. And I'll show you an example of what a type 3 leak looks like in a moment. So here was a 40-year-old male with a 2-month history of positional headaches and tinnitus. Now look at the T2 star image. We see bilateral subdural hematomas. On our post-contrast MR, we see diffuse pachymeningeal thickening and enhancement. Here's a patient's total spine MRI. So these are T2 fat-saturated images. And you can see that there's a dorsal SLEC in the cervical spine, and then in the thoracic spine as well. You can see a small collection, and then you can nicely see it here on the axial images, this crescentic collection here, dorsal to the fecal sac. And then on the KISS images, we saw what looked like maybe there's a disc herniation in the thoracic spine that looked a little funny. So now we're SLEC positive, so we think there's a type 1 or type 2 leak, a fast leak. So this patient's going on to dynamic CT myelography. So here's the dynamic CT myelogram in the sagittal position. Patient's lying prone, you can see the contrast pooling in the fecal sac, but notice that there's a second line. This is called the split ventral sign. There's a line of contrast in the epidural space next to the intrathecal contrast. And then on the axial image, we saw this bony calcific spur, and then next to it, there was leaking extravasated ventral epidural contrast. So this is a type 1 CSF leak. Next, we had a 28-year-old female with a 2-month history of progressive postural headaches interfering with her ability to work. Here we have sagittal and coronal brain MR images. Notice that the pituitary gland's a bit enlarged. There's narrowing of the mammato-pontine interval. We have diffuse pachymeningeal thickening and enhancement. And look at that distal third of the transverse sinus is bulging convex margins, so venous distension. Here's the patient's total spine MR. These are T2 fat saturated images. We see a big SLEC dorsally along the whole thoracic spinal canal. So we're SLEC positive. Again, we're thinking type 1 or type 2, fast CSF leak. Patient's going on to dynamic CT myelography. So here are sequential axial images through the upper thoracic spine. The patient is, again, prone here. And then in the left dorsolateral epidural space, early on, you start to see this faint area of contrast in the epidural space, and it progressively opacifies over time. And then on the coronal reformats, you could see this little bizarre diverticulum, which was the culprit. So this was a type 2 CSF leak, leaking meningeal diverticulum. Now, this was a 68-year-old female with progressive cognitive decline and visual disturbances. Here we have sagittal and coronal brain MR images, and you can see here there's diffuse pachymeningeal thickening and enhancement on the coronal, and then notice that there's marked narrowing of the distance between the optic chiasm and pituitary gland, suprasellar cistern. Patient went on to total spine MR. These are T2 fat saturated images again, and we did not see anything that looked convincing like a SLEC. So now we're SLEC negative. We think there's a slow leak. This is going to be a type 3 leak CSF venous fistula. So we're going to bring the patient over to fluoro and do a digital subtraction myelogram. So here's the DSM. This is the patient lying left side down. And you can see on the first phase, here's intrathecal contrast, but notice there's this faint reticular network of enhancement that progressively becomes more obvious on the second phase. And then by the third phase, you're actually seeing another vein linking up with it. So this was a case of a type 3 leak. We take all of our DSM patients over to CT for a post-procedural study. And in this case, this was the leaking diverticulum, but we did not see the paraspinal veins on CT. So in these patients, we found you really have to do digital subtraction myography to identify the type 3 CSF leaks. And now I'll move on to interventions. So this is a standard approach that's used by many centers. So for type 1 and type 2 leaks, they'll often undergo a targeted trial of epidural blood patch with or without fibrin glue. If that doesn't work, they go on to definitive surgical repair. For type 3 leaks, CSF venous fistulas, they often have targeted fibrin glue injection under CT. If that doesn't work, then endovascular embolization, and lastly, surgery if that's unsuccessful. And then if we don't see any leak on our dynamic myelograms, we could try a non-targeted epidural blood patch or fibrin glue and repeating the myelo if needed. So for epidural blood patching, the way that this works is the patient's own blood is injected into their epidural space. And why this works is because you're creating mass effect in the spinal canal with the injected blood, and it's going to displace their spinal fluid up into their intracranial compartment. So it's going to cause temporary relief of their positional headaches. And also the blood will disperse throughout the epidural space, and it often seals the site of dural defects. So it's sort of diagnostic in a way and therapeutic. And typically the way we do this is we'll drop 5, 10 cc syringes of the patient's blood, and we'll inject as much as the patient can tolerate, usually 20 to 30 milliliters. And you can add fibrin glue to this mix. You can do it in a blinded or non-targeted way where you do the puncture at L2-3 or L3-4, like in this case, and inject the blood. Or you can do targeted. If you've seen a culprit lesion on your dynamic CT myelogram, you can put the needle at that location and do a directed blood patch. Now, targeted versus non-targeted blood patching is controversial. There was a paper by Cho back in 2011 where they found that doing a targeted blood patch was much more effective, 87% effective compared to non-targeted at 52% effective for causing long-term symptom relief. However, a more recent paper by An showed that doing a targeted versus a two-site blind at the cervical thoracic junction and at the lumbar spine was pretty much not statistically significant difference for durable symptom relief. And then CT guided fibrin glue injection for type 3 leaks, CSF venous fistulas. This method's become popular. Mark Momluk at Kaiser Permanente in California sort of pioneered this. They had 13 patients that they directly treated with CT fluoro-guided fibrin glue, and they found that 10 out of 10 had resolution of the fistula on post-procedural myelographic imaging, and all 13 patients had complete symptomatic relief and resolution of brain sagging on MRI. The way that this is done is you place a 20-gauge needle under CT fluoro guidance to the junction of the nerve root and paraspinal vein, and you inject 2 to 4 milliliters of Tacil fibrin glue, and that creates mass effect on the fistula and obliterates it. And then there's transcatheter venous embolization for type 3 CSF leaks. This has also become more popular. The IR people at your shop may offer this service now. This was pioneered by Brinjikji at Mayo Clinic, and in their most recent publication, they had 40 patients with CSF venous fistula detected on DSM. they did selective venography and embolization on those patients, either through an internal jugular or femoral vein approach, and they would inject onyx, liquid embolic agent. They found optimal technical results in 90% of cases. 90% had at least mild symptomatic improvement, and 82.5% had very good symptomatic improvement. And this is a case from my practice partner, Neil Madon at Brigham. And here's a DSM showing that diverticulum with a little vein coming down from it. And this catheter was run up through the azygous vein with a microcatheter out into the paraspinal vein, and onyx, liquid embolic agent, was injected. You can see on the post-procedural CT all of this hyperdense embolic agent obliterating the vein. And then lastly, there's operative management. Again, this is usually reserved for those patients that fail to respond to the minimally invasive interventions. And the surgery varies based on the type of leak. Dural tears, type 1 leaks, and type 2 leaking meningeal diverticula can be surgically ligated. For type 3 CSF venous fistulas, they can either be ligated and or cauterized. And the studies have shown that you want to treat these patients as early as possible. The optimal post-surgical outcomes happen if you treat these patients within 12 weeks of symptomatic onset, although a lot of patients have delayed presentation, as we talked about. And so this is a photo from our neurosurgeon at MGH, Ganesh Shankar, who we work closely with. This is a high-resolution intraoperative microscope photo. And here, this is showing this ellipsoid defect within the dura. And this white thing here is a bony spicule from the end plate. And this was resected, and the dural defect was just stitched up, and the patient recovered quite nicely. So in conclusion, spinal CSF leaks are a very under-recognized cause of neurologic deficits and may go underdiagnosed for sometimes years. And I'd like you to look for those findings of venous engorgement and brain sagging on any MRI you read for the indication of headache. You will find these patients out there. And type 1 leaks from dural tears and type 2 leaks from meningeal diverticula are the most common causes of SIH and CSF leaks, and they're going to cause SLecs on your spine MRI. For type 3 CSF venous fistulas, those are slow leaks. You'll have negative SLEC on your spine MRI. And your imaging algorithm, dynamic CT myelogram versus DSM, is going to depend on your pretest probability of type 1, 2 leak versus type 3 leaks. And treatment should start with percutaneous intervention, and if unsuccessful, move on to surgery. So thank you for your attention.